So obviously that would be bad, but if I don't have blood anywhere, that's bad. There again, when somebody goes into cardiac arrest, the reason we're doing chest compressions and pumping on the chest is we're actually trying to get blood to the brain. It's not so much that we're trying to start the heart. Yeah, we care about the heart, but what we really care about is the brain, okay? So let's go into VFib a little more. So this is what it looks like. So this is two different variants of VFib. Some books will say coarse VFib, fine VFib. Either way, this is what you're going to notice. You don't have any normal. So let's draw a normal one again. Okay. What you don't have is a normal beat. And you definitely don't have normal complexes. What you see in VFib, for instance, is these what are called fibrillatory waves, where there was nothing to actually cause the signal to go down in the ventricle and depolarize the ventricle. So the ventricle is now getting irritated, and it's just pacemaker sites down here in the ventricles are just firing like crazy. It's saying, hey, can somebody just please tell us what to do? Somebody, is anybody going to be in charge today? And so now it just becomes very chaotic down here in the ventricles. And so we have these chaotic fibrillatory waves. Whether it's coarse VFib, fine VFib, it don't matter. It's VFib, and we're going to treat it the same. So anytime they have fib, we're going to defib the VFib, right? So one of the urgent treatments is defibrillation. By the way, what's the difference between defibrillation and cardioversion? Okay, on your cardiac monitor, when you hit defib, so you got your little shock button, okay? So you've got your little shock button. When you're just defibrillating on the cardiac monitor, you're going to push the shock button. First you're going to charge it, or as soon as you push the button, it has to charge because it starts off with 0 joules of electricity. It has to actually charge to whatever you have it set at. So for instance, it may be that depending on your monitor, it could be that you're using, for instance, 200 joules. It depends on the monitor, but just go with what you've been taught and go with the manufacturer of the monitor you're using. Of course, we still need to follow protocols, but every monitor is different. So first, you have to charge. The defibrillator has to charge. So for instance, in the setting of cardiac arrest, while somebody is pumping on the chest, you can be charging during that point. But just remember that before you push the shock button, that you and everybody else, all the other responders, are clear of the patient so nobody accidentally gets electrocuted, okay? So let me just say that again. We defib the VFib, so you're going to charge the defibrillator to the appropriate settings. But while it's charging, often there's an audible sound like beep. Okay, while that's going on, chest compression should still happen. And the reason for that is we want to minimize chest compressions, or we want to minimize interruption in chest compressions to no more than about 10 seconds. So, and according to ACLS, we're only doing our rhythm checks, or we're only doing pulse checks, for instance, every 2 minutes during those 2-minute cycles. But when we're switching rescuers every 2 minutes, for instance, during that same time period where we're switching the people out so that whoever's doing the chest compressions is not getting tired. Obviously, we know that CPR is very tiring, but during that same period of the personnel switch, that's where you're going to check for a pulse, do a rhythm check, and all of that should take no more than 10 seconds. The sooner, the better, okay? So while you're charging, still continue pumping on the chest, but make sure you clear before you actually push the shock button, okay? So in addition to defibrillation, the next thing they're going to need is high-quality, continuous CPR. Of course, currently, we know that we're going to do compressions to ventilations in a ratio of 30 compressions followed by 2 breaths. And this is always in an unsecured airway. What I mean by that is there's no tube coming out of their throat. So now that tube can be an endotracheal tube. It could be, for instance, one of those supraglottic airway devices. I remember long ago when we had combi tubes. Anybody remember that? Combi tubes, and then we had King Airways, and then we had LMAs and I forgot what it was called, but there are all kinds of supraglottic devices. Now there's like iGel, things like that. Obviously, they've become easier and easier to use. and many of them don't have to have you don't have to have like a laryngoscope to use. But if there is if there is not a tube coming out of the throat, we want to do compressions to ventilations in a 30-to-2 ratio. So 30 compressions, and then you have to stop long enough for you to give 2 breaths at the same time. If you don't do that, if you try to breathe while somebody is doing chest compressions and they do not have a tube coming out of their throat, what happens is there's this pressure that builds up from pushing on the chest, from doing high quality CPR. There's a pressure that builds up. There's another pressure from just positive pressure going into their airway from you squeezing the bag. What happens is those two pressures kind of collide. It takes the path of least resistance, goes down the esophagus into the belly, and you're going to cause gastric distension. You're going to hyperinflate the belly. Well, when you hyperinflate the belly, now there's extra resistance. There's extra pressure there that, for instance, can put pressure, for instance, on, let's say, the inferior vena cava, and you actually prevent more blood from coming back to the heart. So that's why it's so important that in an unsecured airway, you never do compressions and ventilations at the same time. Everybody good with that? Okay. However, if they do have a tube down their throat, you've got a way to be able to relieve some of that pressure now. And if they have a tube down their throat, then you're going to do continuous chest compressions for 2 minutes straight. And then you'll do 1 breath about every 6 seconds or so. But there again, follow your protocols, okay? So in addition to that, of course, we're going to use, for instance, every person in cardiac arrest is going to get epi. Now, why do we do that? What's the purpose of the epi? Well, we know that epi, for instance, is a hormone. We talked about where it comes from. It's in it's produced, for instance, in the adrenal medulla. But the purpose of the epi, can you see that? Okay, so the purpose of the epi is ultimately we're going to activate cyclic AMP, cause that sympathetic response, activate those beta receptors, also those alpha receptors. So number one, we're hopefully going to get an increase in the heart rate, but and restore a normal heartbeat. But the other thing we're trying to do is we're trying to get vasoconstriction to happen. So we're trying to activate those alpha-1 receptors to cause those endothelial cells around the blood vessel and those the smooth muscle around the blood vessel to actually constrict, and that's going to cause vasoconstriction that would ultimately bring back the blood pressure, because in cardiac arrest, their blood pressure has dropped down to nothing. They have no mean arterial pressure, essentially. We're trying to at least get perfusing pressure again, okay? And then, of course, if they, remember, what are the ventricles depolarized by? Let me first talk about, we know that the atria are depolarized by calcium, so that's why we're going to often use a calcium channel blocker for those kind of situations. However, the ventricles are a part of the 99% normal things that are depolarized by sodium. So for ventricular dysrhythmias, we will often need a sodium channel blocker, for instance, something like lidocaine. Okay, we could also use a class 3 antidysrhythmic like amiodarone. There again, just follow your protocols, okay? So let's just recap that. For VFib, we're going to have uncoordinated beats, just chaos, just these fibrillatory waves. We need to defib the VFib. We need to do continuous high-quality CPR. For an adult, if we have, let's say, 1 or 2 rescuers or more, if they have an unsecured airway, we're going to do compressions to ventilations at a ratio of 30 compressions, stop, and then give 2 breaths. And then once they have a tube in their throat, then and only then do you do continuous CPR, continuous chest compressions for 2 minutes straight, and 1 breath, for instance, in an adult about every 6 seconds. All cardiac arrest, whether we're talking PEA, asystole, pulseless VTAC, or VFib, all cardiac arrest should get epi, but ventricular problems should also get some kind of ventricular antidysrhythmic, of course. Now, obviously, if you regain spontaneous circulation, so you have return of spontaneous circulation, ROSC, there again, just follow your protocols for how your institution or how your company chooses for you to handle it, okay? Let's keep going. We're still talking about ventricular problems. This is pretty cool, right? We want to be able to tie everything in together.